At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live.
Hello and welcome. I am Donna Cryer. I am your host for GLI Live and so excited to be back from summer hiatus. What a summer it has been. So the intro that you just experienced was just one of the new and fancy features that we have as surprises and new offerings for you at the Global Liver Institute and for GLI Live. We hope that this platform can be even more engaging. We want your comments, your questions, your input on show ideas. We really want to make sure that whether we are talking about policy issues, clinical issues, research issues, or just what it's like to live as a patient, how we approach health and wellness in the liver space, that we are giving you actionable information that is relevant and resonant. And so I could not think of a better way to start this by having our guest today, Dr. Deepali Kumar, who is, amongst her many, many things, is president-elect of the American Society for Transplantation. She is also professor of medicine at the University of Toronto and director of their Transplant Infectious Diseases at the University Health Network. So, for our topic today of what should transplant recipients know about COVID-19, I can think of no better guest. Welcome, Dr. Kumar.
Thank you, Donna. It's really great to be here. Thanks for having me.
Fantastic. So how have transplant recipients been affected by COVID-19?
Yeah, so Donna, this has been a really difficult time for all of us during this pandemic, but I think especially for those that are living with transplants and weak immune systems. You know, many transplant recipients have contracted COVID. We've seen patients being admitted to hospital with COVID, but we've also seen a huge spectrum of COVID in transplant recipients, all the way from mild disease to very severe COVID, where people are hospitalized and on ventilators. You know, we know that being older and having other medical problems like diabetes and high blood pressure put you at risk for more severe COVID. But also the anti-rejection drugs really knock down the immune system, so that can also make COVID more severe. You know, the other way I was going to say that we've really been impacted by COVID is the way that we as healthcare professionals interact with patients. And, you know, that's really changed during COVID. We're using more telemedicine. We're interacting with people over the telephone more, or video calls. And probably a lot of that is here to stay, I would say.
I certainly hope so. But I want to get to an earlier point that you made, that there doesn't, although there are risk factors that you articulated so well, as an individual transplant recipient, of which I am one, there's really no way to know if you as an individual will have a mild case or will have a severe case that might end up in the hospital, or would have long COVID symptoms. You know, there's just really no way at this point to predict in which category you will be. Is that true?
Yeah, I think that's true for the most part. when we do research and we try to figure out who's going to get sick and who's going to sail through COVID, we do it on a population level, and we look at risks. So it's all about your individual risk. So if you're older, you have a greater risk. If you have diabetes, you have a greater risk. Kidney problems, you have a greater risk, etc. But when it comes down to your own individual risk, it is hard to predict if you're going to have a very mild course or if you're going to end up in the hospital.
So I think that it's important for everyone to do social distancing and masking and take precautions, since you just don't know exactly how, even if, I have my transplant was because of autoimmune issues. And so my immune system, typically knocks out all comers. And I look over at my husband and I'm like, why do you have a cold? I don't understand. What's this cold thing that people get? And yet we have no way of knowing. I could come down with a very severe, case of COVID. So it's not something that I feel like I'm going to sort of gamble with and hope that I am one of the lucky ones with just a mild case. And so that's why I was, first in line, as first as I could be, given the initial prioritization to get a vaccine. And I know we've worked so closely together, GLI and the American Society for Transplantation, to get a third shot for transplant recipients and those who are in some very specific categories of immunocompromised. Can you tell us the path to that, and why that was needed?
So, the third dose is being recommended because research showed that 2 doses just wasn't good enough in terms of getting a good immune response. So after 2 doses, actually less than half of transplant recipients made any kind of antibody response. And even those that made some antibody, they made it at such a low level that it probably wasn't very protective. So the FDA and CDC made this recommendation to get a third dose for those who have weakened immune systems. And, the other reason the third dose is important is because to get protected against the Delta variant. We know that you need higher levels of antibodies to be protected against Delta.
As we went through this experience together as a community, I think this was a little different for several reasons, of course. But one was because so many patients were in the vaccine effectiveness studies, and we are very much at GLI about promoting a culture of participation in research, so that we have data to answer the questions that we're asking. But patients were seeing in real time, patients who were in those studies, that they had 0 antibodies, that were not responding, and we understand. I mean, we'll talk a little bit more about the other parts of the immune system that we're still trying to understand how those are activated to put together an actual immunity picture. But you would see people with their lab results and sharing them with others, and so I think it made the expectations of the transplant community much higher for what we wanted to see from an advocacy perspective, and putting that picture together with the research to push for this change. So I think that the role of the patients with access to the data was really transformational in this, and perhaps can engage more patients in research. That's certainly my hope.
Absolutely. And, I think one good thing that has come out of COVID is exactly this, is how we can use research and advocate at the same time. It's both of these things really go hand in hand. And I think these vaccine effectiveness studies that people participated in really, and got their results back in real time, really exemplifies the way that we should be doing research going forward. Absolutely.
So, one of the things that came out of this was something that we are told, but something I think for a lot of patients, myself included, sort of goes over our head when we're first transplanted, that there are a lot of vaccines that we don't have an optimal response for at the same level of the general population, like the flu shot perhaps, but it makes it even more important that we get them. Can you talk about sort of other vaccines for transplant recipients and the importance of them, and but also our sort of expectations for us?
Yeah, so once you have a transplant, because of the anti-rejection medication, the weak immune system, you are susceptible to all sorts of different infections. And so the recommendation has always been to get vaccinated for the infections that we have vaccines for. So we have flu shots, hepatitis B shots, pneumonia shots, and so on. But what we know is that even though there's this recommendation out there to get vaccinated, we know that these vaccines don't work 100% of the time. And that's actually a fairly well-known fact in those of us that actually work in this field. So I would say, when we learned that COVID vaccine did not work as well, some of us were surprised, but others were actually not surprised. I think the expectation really for COVID vaccine is a little bit higher. So we know that other vaccines don't work very well, but the other diseases also don't cause as much of a problem, I would say. Either they don't happen as often, or if they happen, there's a treatment, or they're not as severe diseases. So even though everybody should be vaccinated against, all these other things, COVID, the fact that COVID can be a very bad disease just makes that whole expectation a little bit higher. And I think that's where our high expectations come from. We really don't want this terrible disease to be, affecting us and our loved ones.
Absolutely. I also serve on the board of a hospital, and we get weekly updates as to our census of how many people are in the hospital, how many are on the COVID wing, our capacity to take on non-COVID patients when COVID is very high. And I think for me, that's very anchoring, in the realities of delivering care on the ground and trying to provide or wanting to provide both COVID and non-COVID care to people. And I think that as I think about the role of the COVID vaccination for transplant recipients and our caregivers and those who love us and interact with us, and now as we're starting to go back to work or school, work with us, it's so important, not just for COVID, but to be able to have new transplants being done, and to, if you had a problem as a transplant recipient or any type of liver patient, to know that there is a hospital bed available for you that's not being taken up by a COVID patient. And so, for those who are hesitant to take the vaccine, I want them to understand all the ripples of implications of protecting everyone around them and the capacity of the healthcare system.
Absolutely. And, the implications are huge. When we have such severe waves of COVID that impact our hospitals, they fill up the ICUs, and it really impacts all the non-COVID care. And I'll tell you that right at the beginning of COVID last year, when COVID first started, the whole transplant system was affected because of
Right.
this, first wave. We had a drop in the number of transplants that were being done, including both deceased donor and living donor transplants. We had to really scramble and make protocols to keep transplantation going and make sure that our recipients were safe, our donors were being tested. And I think there was a huge concerted effort made to keep the whole transplant system going. And since then, I think, we've got great sort of protocols in place. So now through this fourth wave, we're handling it very well, and we're able to keep non-COVID care going at the same time as COVID care. So I think it's a lot better now than it was definitely in the first wave.
I remember, conversations with CMS and others to make sure that it was designated as an emergency, service. Hearing from patients that one day they needed a transplant, or else they weren't going to live, and then getting a call saying, "Well, your transplant is canceled." They're like, "Well, which is it? Am I, do I have a serious condition in need of urgent activity?" Or should I be waiting for months and months and months? And so to put that prioritized status back on transplantation, and working with hospital systems to make sure that they had the staff and the nurses, the PPE, separate entrances and protocols and everything to enable life-saving transplants to continue. So very important. And I really want to thank the work of the American Society for Transplantation for, your advocacy and your push to make that possible for, everybody who's gotten a transplant in this past 18 months. Should realize all of us who are fighting to make that, possible during this time. So I wanted to ask, though, as we now are reopening to some extent, and there are more and more events, or there are more workplaces that are requiring workers to come in at least a few days a week, or children going back to school, or people who are teachers with transplants being asked to go back to work. How can transplant recipients do some of those activities safely? Or minimize risk, at least?
Great question. If you're immune compromised or with a weak immune system, I would say just be careful. I think it's, if you look at it, we all need to live. We all need to do our daily activities, and it's perfectly fine to go about doing your daily life, but just do it in a safe manner. So, some of the very basic things, like wearing a mask in public places, washing your hands, avoiding crowded places. If you can go to a mall, you can go to a store, or go to the movies, but maybe try to do it when it's not peak time. Right. If you're going to visit somebody, I don't think it's so bad now to ask people if they're fully vaccinated. So ask them if they're vaccinated. Maybe limit your social circle, and make sure that your social circle is also fully vaccinated, and that the people you live with are vaccinated. I think for work and school, I think we have to consider individual situations. Many workplaces now have vaccine mandates. Discuss your individual situation with your employer, especially if you're in a line of work where exposure risk is high. Is there work or school that could be done online? Are there easy changes that you can make to your work to make it safer? So people do find ways to minimize the risk at their work. And then, know what's going on in your community. So if there's an outbreak happening at your workplace, or if there's an outbreak happening at school, just be aware of that. I think just the heightened awareness, I would say, it protects people. And then finally, get vaccinated. Get vaccinated yourself. Even if the vaccine doesn't work 100%, it's very likely that it's going to be at least partly protective. I mean, we know that from other vaccines, that even if those other vaccines don't work 100%, they protect people at least partially. So I think the vaccine part is actually pretty important.
And the safety, it has never been in question really for the two mRNA vaccines, the Pfizer and the Moderna, vaccines that have had the most evidence built up at this point for the 2 doses, and that we're talking about for the 3rd dose. And so, when I talk to patients who, sort of talk about, well, the efficacy, I'm like, but the safety of the vaccine compared with the how difficult and how dangerous getting COVID can be, it doesn't seem to even be, I don't know, it's a no-brainer to me. I'd much rather have the vaccine than get COVID, because that's definitely an unsafe situation.
Absolutely. Yeah. I mean, the safety of the vaccine is not a question at all. In fact, first of all, we know that in the general population, millions and millions of people have been vaccinated. In the transplant population, hundreds of thousands of people have been vaccinated around the world. And everyone is, I will say that a huge number of researchers, doctors in many countries are looking at their transplant populations and reporting on any side effects. So if there was any signal, we would know right away. And so far, there has been absolutely no signal that there is any kind of increase in side effects or any kind of impact on the organ itself. That's always something important to consider, but we have not seen any impact of the vaccine on the transplanted organ.
Excellent. Or the host.
Or the host. That's right. Both.
The host too.
That's right.
And so, and maybe we have time to sort of bust some other myths too. There's no tracking chip in the vaccine, correct?
Not at all. Nobody's tracking you, believe me.
I love the people who are carrying around their iPhones at all time, or their Android phones or whatever, are worried about being tracked. I'm like, your phone is tracking you more than anything else. So no chip in the vaccine. On perhaps a little bit more serious note, it's not making people infertile.
That's right. In fact, there's lots of data now on pregnancies and so on, and there has been absolutely no signal of infertility at all. People have had babies after getting vaccination, so there's absolutely nothing to worry about there.
Okay, great. Those are the top 2 that I hear most often. So I just wanted to make sure that we had gotten them out of the way on this show. So there are some treatments, though, either given prophylactically or after someone is hospitalized, at least if they can get in the early days. Can you talk a little bit about the antiviral treatments and monoclonal antibodies and what that looks like?
Yeah. So if you do end up with COVID, some places are providing monoclonal antibody treatment. And as a transplant recipient, you would be eligible, you'd be in the risk category, and you would be eligible for those monoclonals. Now, the problem with monoclonals is that they work if you get them quickly. So it really depends on, so what you need to do is make sure you get those monoclonals within a few days of your symptoms starting. So that kind of means, first of all, being very vigilant that your symptoms could be COVID, and then getting tested right away. And then if you're positive, then contacting your physician, your transplant center to get to see if you're eligible for these monoclonals. So that's the monoclonals if you're sick, and then going to, if you get sicker and you end up having to go to the hospital, Then in the hospital, there are treatments like antivirals, like remdesivir, that is given to anyone that needs oxygen. And then also medications that reduce inflammation, like dexamethasone, like something called tocilizumab, which are given to people who are, again, on higher levels of oxygen. So there are definitely treatments in the hospital. Now, the question that I get is prevention, absolute prevention. One of the research questions that's being looked at is whether monoclonals will actually work in a preventative way. So when we talk about vaccines, we talk about active immunization. So we're giving somebody a needle, we're actively getting their body to make antibodies. When we talk about monoclonals, we think of it like passive immunization. We're just giving you the antibodies. And so there is some medical literature to suggest that just giving somebody antibodies passively might help to protect them from getting infections. So, but I guess the issue is we don't have a lot of information on that for COVID. And I think that's the kind of research that's ongoing to try to figure that out. Now, monoclonals also don't last forever. So you may get it, it's an injection. So you might get an injection of monoclonals. It may last for a few weeks and you might need another injection. So it's not a one-time thing by any means if you're using it in a preventative manner.
It's been interesting to me to have people who don't want to get vaccinated, but then do want, monoclonal antibodies and every type of other treatment, which are far more, invasive or long-lasting. Or I'm very glad that we have them, but it seems a much simpler thing to do would be to get, just stop at a CVS or a Walgreens or a Walmart or something, or your doctor's office, and get a vaccine and go about your business.
Absolutely. I mean, it's so much easier just to get vaccinated and then have it done with, rather than repeatedly going back and getting monoclonals. And then, monoclonals are medications too, and they have side effects. So that's important to remember.
I know you're in Canada, so where the health system is very different, but my understanding is that many of these, treatments are in the United States are in fact, free, or that the government has purchased, several amounts. And so people should not be afraid if they are recognizing that they have symptoms of COVID to identify themselves for care early, and potentially have access to these treatments. Is that?
Absolutely. I mean, you should not, there's no concern about the cost, and, there are treatments available for COVID. So it is important to, exactly like you said, Donna, to identify yourself early and get treated.
So, what types of research, moving forward, are the most helpful, as an organization, in touch with a lot of patients who, want to be helpful to the research enterprise, want to have questions answered. What type of research is ongoing, and how can we help research in testing? I know is one area. Research in monoclonal antibodies. Tell us about how we can help advance research in this space.
So, there's all kinds of research going on. Research, in terms of the different treatments, the immune response to COVID, vaccine research, monoclonal antibody research. So there's all sorts of research going on. And I think, we can all definitely help to advance research. I think there is research going on somewhere in there's research going on everywhere in the country. So I think start local and ask your transplant team if there's any COVID research going on in your local transplant center. Or even, outside your center would be okay, if you're willing to travel or willing to do remote research. And there are some research protocols that will allow for people to participate remotely. So definitely, look for it there. I would say if you have connections with other transplant recipients, like on social media or personal connections, then spread the word.
Me too.
Absolutely, and I think that really helps. If people that are listening belong to an association, look on their websites for research. Again, spread the word through your association. And as we talked about before, research really helps, and we've seen that in COVID. COVID is a firsthand example of how research has had a direct impact on our treatments, on our vaccines, and by participating in research, you really have the opportunity to make a big impact. For example, I can tell you that the third dose vaccine recommendation is really as a direct result of research that transplant recipients participated in. So you really have, research makes a big impact, and it helps the individuals and it helps others.
Well, we have research opportunities that are linked in our COVID-19 updates. We'll put some in these show notes. And we'll also be doing a better job of curating some of those opportunities for patients, particularly to participate in remotely, which is, what I do. I answer some surveys online. I send in blood work through my, local LabCorp, which I can enter at a, non-peak time of day, and send that lab work in. And it's been a really great experience to sort of do my part as the beneficiary of so much research that has kept me alive to this moment. I feel a real responsibility to pay it forward and to contribute to research, and so it's highly encouraged. So Dr. Kumar, thank you so much for this conversation today. Thank you for all the work that you do at all your jobs on behalf of transplant patients. And now I think we'll play us out.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.